Welcome to Who's In, Who's Out, Deciding Which Patients Are Right for Your Hospital at Home program, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine and the American Hospital Association. We'd also like to recognize the generous support of the John A. Hartford Foundation for the Users Group and for this webinar series. It's now my pleasure to introduce our moderator for today's webinar, Dr. Linda DeCherrie. A member of the HAH Users Group leadership team, Dr. DeCherrie joined the Mount Sinai Visiting Doctors Program after her fellowship and is currently the director of the program, which provides primary and palliative care for homebound patients in Manhattan. Today, and even more relevant to today's program, she is also clinical director of Mount Sinai's Hospitalization at Home program and a national expert on hospital at home implementation and practice. Please take it away, Dr. DeCherrie.
Thank you so much. So I just want to tell everyone a little bit about the Hospital at Home Users Group for those of you who aren't familiar with us yet. We have our web address and our Twitter handle listed there. Please follow us. The Hospital at Home Users Group is a group of hospital at home programs. You could be just starting up, or you could be an established hospital at home program. And we would love for you to go to our website and sign up to be part of our users group. In addition, on our users group, we have a new technical assistance center, which links to recordings of these webinars. It also has other useful facts and information about hospital at home, the model, and how you might start one up. So please go ahead and do that, and we think it'll be very useful for everyone. I want to say, here's a listing of the webinars coming up. And you can see the one next week, next Tuesday, 2/2 at 4 o'clock is the next one. And there's a whole list right here of all the webinars. I want to say we are also going to have these technical assistance office hours coming up, and we're going to have a slide at the end about that, where you can just literally drop in and ask any questions that you have. There's no predetermined presentation at those office hours. You just drop in and ask your questions. You do need to sign up so it's not 100 people all dropping in, but when you do that, you can join and ask your questions. So most importantly, let's get to what we're talking about today, which is who's in, who's out, deciding which patients are right for your hospital at home program. And we have two great speakers today. Next slide. I'm going to introduce them both. So Dr. Pamela Saenger is the lead provider of the Hospital at Home program at Mount Sinai, which she joined in 2017. Since then, she has worked with the interdisciplinary team to build out internal quality improvement, tailor the EMR to better serve the needs of hospital home clinicians, and launched the hospital home pilots for post-surgical and oncology patients. As part of the Sinai team, I know she is passionate about improving hospital at home care, as well as working to make it accessible for more patients. And secondly, we're going to have Dr. Elizabeth D. Pirro. She's an internal medicine physician and medical director of the Presbyterian Complete Care House Calls and Hospital at Home program. As part of her training, she completed an internal medicine residency at Johns Hopkins Bayview Medical Center, where she had the opportunity to work with my colleague on the users group, Dr. Bruce Leff, in the Elder House Call program. This experience led her to get involved with the Presbyterian Hospital at Home program in 2010. So now I'd like to turn it over to our two presenters.
Thank you so much, Linda and John. I know Dr. DePiro and I are both very excited that you're all here today to learn about patient selection when it comes to hospital at home. Just some learning objectives and sort of orienting where we are. So in this presentation, we're not going to be recommending a specific set of inclusion-exclusion criteria. We're going to cover in some broader strokes how to approach coming up with your own selection criteria that are specific to your own programs. We'll talk about how your target population will shape your most basic criteria, which involves where you're recruiting from, emergency departments, floors, the age range, geography, and the hospital service you'll be looking to get patients from. We'll talk about the different domains you'll have to consider when evaluating patients for HA care. What are their clinical needs, the social needs of the patient, the home safety, the appropriateness of the home environment, staff safety, and others. And we'll talk about how you can develop customized criteria based on your own program structure and capabilities, and how, as your program matures, those criteria may change over time. So next slide, please. So to get started, we're each going to tell you just a little bit about our own HA programs. Go ahead, Isa.
Hi, good afternoon, everyone, and welcome. So I'm going to tell you a little bit about the Presbyterian Hospital at Home program. It's based in Albuquerque, New Mexico. We've been up and running since about 2008. We are part of a large integrated health system that includes hospitals, primary care clinics, specialty clinics, and importantly, a health plan. That allowed us to start this program early because we had a health plan that was willing to pay and invest in developing this program. Our initial goal was to try to offload the hospital, and we were a diagnosis-based program in that we started with a group of 6 diagnoses that we could take to hospital at home, and these patients were coming from the emergency room or from the inpatient setting, which is now, of course, part of the Medicare waiver requirements. Our patients were adults over 18 years old. Again, they had to be part of Presbyterian Medical Group, as that was how we paid for this program. Albuquerque is a relatively small city in a very rural state, so we serve surrounding communities, and one of our limitations, of course, was distance to a hospital. In case patients need a higher level of care, they have to have access, and that's at some of our limits. We have served a large number of patients in the past several years with excellent patient satisfaction scores, as well as very good scores for 30 and 90-day readmission rates, especially when you compare that to the brick and mortar readmission rates. Pam, she's going to tell us a little bit about her program. Next slide, please.
Thank you. Yeah, so some highlights about the Mount Sinai program. It was started in 2014 as part of a CMMI grant. At the time, it was Manhattan only. We recruited from 1 emergency room. We did both ED admissions, clinic referrals, home admissions. Started with a short list of eligible diagnoses. I think it was 5 or 6 diagnoses. And in 2017, we relaunched with our joint venture partner, Contessa Health, and started to expand. So we added 3 more emergency rooms in Manhattan to recruit from. We added a couple of new insurance payers now that the grant period had ended, and we further expanded that list of diagnoses. And now at this point, we don't really recruit based on a diagnosis list. We think more in terms of treatment plans. And then just this last year in 2020, we launched CHA, what we call Completing Hospitalization at Home. And that was in response to the pandemic-related public health emergency. And that was when we could first start taking patients from hospital floors to complete their hospital stay at home. And shortly after that launched, we started to take COVID-positive patients. To date, we've served over 1,100 patients between HA and CHA. And now we're taking patients who live in all of the boroughs except for Staten Island. And as I mentioned, a treatment-specific recruitment workflow rather than diagnosis-specific. And through the years, we've managed to maintain a pretty low readmission rate, 30-day readmission rate, and our satisfaction scores are fortunately still doing well. We can go to the next slide. And Gabby, you can go ahead. This has some animation. You can go ahead and just fill it all in. So when Isa and I were working on this presentation together, we sort of wanted to brainstorm sort of what's behind the exclusion criteria and why are they important. We came up with this list of 9, and we could probably have doubled or tripled it. But we just wanted to highlight some of the things that it's going to do for your program. So first of all, hospital level care. This is, obviously our mandate is that hospital at home is providing hospital level care for our patients. I think for many clinicians who you'll be working with to get patients onto your program, this is an unfamiliar care model. And I think for some, it's a bit of a leap to fully understand what it is that hospital level care at home means. And there can be a tendency on the part of some partners to see HA sometimes as a souped up transitional care service, or an alternative or complement to a home health episode or a home infusion service. And so again, since our mandate, and especially through the waivers to be providing hospital level care, this actually remains a front and center selection criteria that we consider for every patient that comes to our program, whether they're coming from the emergency room or the floor. This most often comes up when we're taking patients who are already admitted from the floors. You also want to think about the care that aligns with patient goals, and building into your criteria, assessing the patient's priorities. Is this a patient who wants everything done, or is it a patient who may want to maximize time at home, potentially at the expense of more intensive monitoring or potential procedures? So figuring out a way to review that when you're selecting patients as well. Of course, your criteria will help you to ensure patient safety, satisfaction, and trust, as well as staff safety, which is, of course, is a major priority. We'll get to more details about all of those things later. And I'll turn it over to Isa to continue with this slide.
So again, continuing with some of the general ideas to think about when you're trying to come up with your inclusion and exclusion criteria, I think an important part of that is to streamline decision-making process. You're going to be working with multiple other partners, physicians or providers in the emergency room, providers in the inpatient floors, discharge planners or case managers. And if you have a streamlined process that's very clear and concise, that's easy to follow, it's going to help you get more referrals to your system and help you be more effective in the community. Obviously, having a streamlined decision-making process is something that is going to help maintain quality. It's going to help you admit the right patients for your service, for the care that you can provide. That is also going to translate into better outcomes in the long run. So you really have to work on having some kind of criteria that you use in selecting your patients and deciding what your model is going to be for the care you provide. That also will translate into improved satisfaction of your partners. If you are very accessible, they know who to call, they know when to call, they know how to use you, it's going to improve trust and satisfaction with your bigger team, and also encourage participation. And we will talk a little bit more in more detail about those later. The participation part is important because, as you will find out, it does require ongoing education and interventions to the greater team that you depend on to get referrals. So again, right care, right time, right place is what you need to keep in mind when you're developing your criteria. Next slide, please.
So first, the basic decisions when you're thinking about patient selection. Who is your target population? These are sort of the high level kind of hard inclusion exclusion criteria that you'll have. The appropriate insurance, whether it's just fee for service or you have other plans you can accept. What your geographic catchment area is, and we'll get to thinking about that a little later in the presentation. Your age group, what are your age cutoffs? And of course, requiring hospital level care. The referral location, thinking about where your patients are coming from and who's referring to you. Are these ED providers? Are these hospitalists and other clinicians on the floor? You may want to share sort of that bare bones inclusion exclusion criteria with those people, those partners in the hospital and in the emergency room. And you may want to reserve, the more granular, detailed selection criteria that you create for internal use, just so that you don't sort of burden or kind of intimidate some of your partners who might be referring to you. And then a big question to think about when you're creating your criteria is, of course, target diagnoses versus asking the question, what's the clinical plan? I think most programs, I know ours certainly did, start out with the short list of diagnoses, and I think that's fine. I think what you may find over time is that you might miss some cases who, for whatever reason, didn't get assigned one of your particular diagnoses, but the care plan was something that you could certainly execute in the home. And then also thinking about who your referring services are. So in addition to the emergency room, are you talking not only to medicine teams in the hospital, but also some surgical teams, oncology teams? We've taken several patients over time from surgical teams who were being managed conservatively in the hospital. And so I think not neglecting those groups, those services as a potential source of patients is important as well. I think we can go to the next slide.
And this is sort of a further list of general categories that you want to keep in mind when you're trying to decide which patients you can care for effectively and safely in the home. Things to consider, for instance, are how intensive monitoring can you handle? Are you going to be using telemetry? Are you going to be using continuous vital sign monitoring? How often can someone be in the home? The new Medicare waiver, for instance, is requiring that there is at least 2 nurse visits in the home. Is that going to be RNs, or can you use care extenders like paramedics in the community? Are you going to use telehealth for some of those visits or to provide care for those patients? After hours availability, you know, depending on the care plan for a particular patient, the likelihood of having after-hour complications or calls needs to be considered. And who's going to answer those calls? Is that going to be an overnight urgent nurse, community paramedics? Are you going to have providers on call overnight? Other considerations address diagnostic capabilities. Can you do labs in the home, and how frequently? Importantly, how quickly can you get those results back? Labs need to go from the home to the lab, and then the turnaround time may be longer than ideal for certain conditions to provide safe patient care. How quickly can you get medications to the home? Let's say you take the patient home with a particular care plan and you have all your orders in and the medications that you need are in the home, and then midway through the hospitalization, a new situation arises and new medications are needed. How acute is that need? Are you going to have to wait for delivery? Do you carry a med box with you with some first dose medications that you can quickly leave in place? What about imaging? Can you do EKGs in the home, chest x-rays or other x-rays? What about ultrasound or Dopplers? Line placement, that's an important consideration because you have to have good peripheral access or central access in these patients. We have for the last 12 years had a service called Vic the Pick, and he very nicely goes into the patient's home and can place lines for us, midlines or pick lines. And that actually has been an invaluable service to allow us to provide care in the home for these patients. Clinical capabilities of your staff is another thing to consider. For instance, if your staff has training in certain specialty areas and can handle more complicated patients, Foleys, wound bags, tubes, drains, IV pumps, or as I said, midlines or picks, that will also help to determine if you can provide care for certain patients. As we know, as part of the Medicare waiver, you have to have a plan for physical occupational therapy or speech and swallow therapy. Are you going to be able to provide that in the home during the admission? Medical equipment, that is a major consideration. Many of these patients require hospital beds. You have to be able to elevate the head of the bed. Wheelchairs, bedside commodes, oxygen, a major consideration. How quickly can you get that into the home? Nebulizers and nebulizer equipment. These are sort of critical basic equipment needs. Food delivery for patients with access to food difficulties. Again, you have to have a plan for this. Are you going to use some kind of a delivery service? How are you going to accomplish that? And of course, home health aides, someone to help patients with personal hygiene if family members are not able to do that. Things to consider when you're coming up with your determination for which patients you can include or exclude from your care. Next slide, please. So up to now, we've talked about some general things to consider when you're trying to come up with your criteria. And we did that on purpose because there is a lot of criteria out there for diagnosis-specific inclusion and exclusion criteria for hospitalization, for what level of care a patient should be at, depending on specifics, you know, labs, numbers, temperatures. And we were trying to stay away from very definite or specific criteria because in reality, providing hospital at home care is sort of a bigger picture outlook. You're looking at the patient's goals of care and safety and quality of care. And the specifics that are listed here sometimes are very limiting or very rigid. And we were hoping that you get the message to keep an open mind. Every case can be discussed and then determined whether or not they're appropriate. Just to go through one of these in general terms, for community-acquired pneumonia, some of the inclusion criteria is listed, worsening cough, fever, tachypnea, tachycardia, chest x-ray evidence of pneumonia, elevated white count, elderly patients with multiple comorbidities who may not have some of the basic criteria, but meet hospitalization criteria because of the overall picture of high risk, other organ compromise. Exclusion criteria, pneumonia, as empyema, meningitis, cancer, pulmonary fibrosis, TB, immunosuppression, patients who've been in the hospital recently or in nursing homes. And most of those, if you think about it, are looking at, are these patients safe to be managed in the home? Are they at high risk of complications? Are they at a high risk of a rapid decompensation or unexpected development? The exclusion criteria should not be looked at as absolute, but rather as things to consider on a case-by-case basis and discuss so you can provide safe and effective care in the home with good outlines. I won't go through in detail the congestive heart failure listings, but it's the same idea. Don't get bogged down into specifics, be aware of them. As Pam stated earlier, you want to have specific criteria for your inner team so that everyone on the team can follow them and use them as a guide. You don't necessarily want to publish these to your partners who would probably just be overwhelmed and decide it was too much trouble to call you. But important to have them at some level. Next slide, please.
Yes, totally agree on that last point, Isa. We could probably do the full hour just on the clinical selection criteria, but in the interest of not neglecting some of the other domains, we did want to touch on geography and how that is going to factor in. So thinking first of all about the patient's distance to the nearest ED or hospital, what is their travel time going to look like? Thinking about your vendors and ancillary service providers, what are their catchment areas? Do they go to all the towns and zip codes that you want to service? Thinking about your staff travel time, where are they coming from and how are they getting there? Driving, public transportation, consider the time that they'll be spending in transit and what's going to affect that on a given day, given weather, traffic. And your catchment area, you may decide that it's a miles limitation or it might be a travel time. And it might depend on the program. Thinking about video visits and telemedicine. Geography still matters in that case because are your patients in a service or coverage area? Is there cellular service? Is the technology that you want to use going to work where they live? Might you need to be deploying special equipment to ensure that your telemedicine is going to work? And then I also just wanted to touch on logistics. It's sort of related to geography and two parts there, thinking about weather events. So thinking about just staff and vendor ability to reach patients and patients' ability to travel if they need to be escalated during certain weather events that may occur. In New York City, we have blizzards in the winter and heat waves in the summer. Just a few years ago, we had a blizzard where subways were stopped and roads were impassable for a day and a half to 2 days. So that's something to think about when these big weather events are coming. During a heat wave in the summer, you might want to start asking patients about air conditioning in the home. A lot of our patients in New York City don't have air conditioning. Let's say you're looking at an elderly patient with respiratory complaints, is sending them to a 110-degree apartment the best plan during that time. So you may have some sort of short-term selection criteria in these instances. Similarly with weekends and holidays, going into 3-day weekends, where the Monday is a national holiday, getting ahead of things, talking to your vendors and ancillary service providers and finding out what are they going to be able to provide the same service level. If there are reduced hours or reduced staffing, what impact is that going to have on the types of patients you can admit and the census that you can handle going into that. So thinking ahead in these cases, and you may have to apply short-term criteria or add certain questions to your patient screening that you otherwise don't have to worry about. We can do the next slide.
So along the same lines, some social and safety considerations that should be an important part of your initial screening patients for appropriateness to be cared for in the home is, of course, the home environment and the safety of the patient and your staff in that environment. Things to consider: infestations, access to electricity, water, or food. Substance abuse, that can be a very difficult issue because a patient with untreated and active substance abuse is going to be in the home with an IV that you've provided, and this can become a very big problem and may not be the best place to care for that patient at that time. Drug activity in the home or around the area, is that something that you need to consider as far as safety for your staff? Weapons. We're out in the West where lots of people have weapons. Usually, as long as the weapons are locked away and out of reach, they're not a problem. But you need to consider that depending on your location. Pets. We all love our pets, but they don't necessarily like us, especially a lot of strangers going into the home. They need to be able to be locked up or put away safely for when you're going to be working with the patient. Another consideration on that is the ability to keep the IV, the medications you're going to be given, relatively sterile. You know, is the home an environment where that is really going to be a big challenge and may not be appropriate for patient care? Psychiatric issues, another difficult consideration in deciding whether or not to admit a patient. But a patient with untreated and out of control psychiatric issues may not be safe in their home and may not be able to have a positive outcome, even with appropriate treatment. Other issues to consider is the ability for self-care or the ability to have somebody in the home who's going to provide that glass of water or help walking to the bathroom. You know, one of our major criteria or screening tools in the emergency room was always, can the patient walk? Can they get to the bathroom? Can they get to the phone? And if they can't do that, do they have family members who are willing to provide that care for them? Special populations to consider. This is important in cities or in rural areas. For instance, homeless populations. We've had some success with emergency room social workers being able to get homeless patients into a motel for a week so we could provide their IV therapy. And that also bought time for social services to intervene and try to help get them into a more stable living situation going forward. Other considerations are group homes or managed care homes, as well as assisted living facilities. Some of those facilities do not want patients with IVs there, or they're not comfortable having a patient who has an acute illness being cared for in their environment. So contacting the managers of those facilities before you make the decision to admit is also important to consider.
Yeah, if I can add just a couple points on that slide. Yeah, the sort of facilities and group homes, something we've seen in the pandemic times actually is some of them request that any visiting clinician, anyone coming in to see one of the residents, present proof of weekly negative COVID testing. So that's something, you know, I just want to emphasize. Always reach out to the facility and make sure they understand what your service is, what it entails, and make sure that you can meet their requirements as well. And one other point that, you know, we're in Mount Sinai, we've got an urban population here. I don't know if this other programs will encounter this, but we also see plenty of patients who live in SROs or single room occupancy buildings where they have their own room, but the common space is shared, and that includes bathrooms and kitchens. And generally that's not an exclusion for us, but we always think about each patient case, you know, in isolation. If we have a patient who's getting admitted for gastroenteritis and they're having, you know, nausea, vomiting, diarrhea, is that going to be, you know, a workable solution for the patient? Is that someone we want to send a commode home to? You know, just taking those sorts of things into consideration.
Right. And Pam, you reminded me of another issue from the assisted living facilities. I'm sure in New York, as in New Mexico, the assisted living facilities and care homes have been plagued with COVID positivity. So it's something to consider if you're going to be caring for a patient in there, especially if you have your team separated into people that work with COVID and people that don't, trying to keep the team healthy. And that's another important consideration that we've had to deal with in this environment.
All right, next slide.
Next slide, please.
So just a note about screening tools. We've been talking all about how do you determine your selection criteria, but then once you have your criteria, how are you going to implement it? How are you going to apply it? So what we've done is we've settled on a couple of different tools. We have, on the one hand, we have lists of clinical exclusion criteria, that are, of course, mutable and flexible, that we publish on an internal website for our HA clinicians to refer to when they're considering cases. And then we have a set of, I should say, we have the clinical exclusion criteria that we share broadly with our partners is very short and clear and direct, not nearly as granular and detailed. And then we also have a set of screening forms, which are the tools that we use to do our social screening. And that's where we review social supports, functional status at home and home safety directly with the patients and their caregivers. And both sets of screening tools have been updated innumerable times over the years. We've added, removed, refined criteria countless times. But the key is that they're always accessible from the same place. Our team knows where to access them, and we keep it updated. And we communicate internally when changes are made. But again, those sort of longer lists, more granular tools are not the ones that we tend to share widely with our partners because, one, they're extremely detailed and we don't want to burden them with having to go through all of those lists, but also because they change frequently.
And the only thing I would add to that is that I think this is an important slide because it really brings home the point that when you're deciding what patients you're going to care for, you don't have to just sort of lock yourself into a diagnosis-based model. You can start out by thinking about screening tools and what patients you think you can manage in the home. And the diagnosis then become kind of secondary to that, as long as you can provide safe and effective care. So the screening tools really are essential to any inclusion and exclusion criteria you may develop down the road.
Yeah. Next slide.
So now we're just going to give you a couple of case examples just to sort of illustrate, I think, flexibility as well as the fact that nothing is written in stone. So the first case is a case of community-acquired pneumonia. This was an 86-year-old woman with a past medical history of COPD on 2 liters of oxygen at baseline at home. She had dementia, congestive heart failure, as well as stomach cancer in remission for the past 6 to 8 months. She had failed oral therapy with azithromycin and presented with worsening cough, fever, shortness of breath, wheezing. She had increasing lower extremity swelling and was also wheelchair bound, which was a new development in the setting of worsening illness. Normally, she was ambulatory. She was cared for at home by her husband. Interestingly, in the emergency room, she was requiring 6 liters of oxygen by nasal cannula to stay at 90%. She had bilateral infiltrates on chest x-ray, which was worsening compared to her prior x-ray. She had an elevated white count, acute renal failure, and was also in acute congestive heart failure. So if you think about it, she clearly met in admission criteria for pneumonia, but she also met several exclusion criteria. In particular, the fact that she had a very high oxygen requirement, which some hospital at home programs may not be able to meet those requirements in the home, not to mention that you're going to worry about whether or not that's going to get worse or progress in the next few days. But important, if not the most important aspect of this case was the fact that the husband, who was the main caregiver, absolutely did not want her to go into the hospital. She had been hospitalized several times before and had severe sundowning in the inpatient setting. After her last hospitalization, he felt that she had never returned to her prior cognitive function. And So that to him was the most important thing. He wanted to take her home so she would retain her current level of cognitive function. So we made the decision to admit her to hospital at home because of the patient care goals taking the primary, I guess, position in the decision-making process. We are able to have high flow oxygen up to 10 liters in the home with our program. And she did very well. She was on IV antibiotics. She was on IV diuretics for a couple of days. And subsequently, we ended up admitting her to our complete care program, which is a program that manages mostly elderly patients with multiple comorbidities, frequent emergency room use or hospital use. And we basically serve as a primary care clinic with house calls. And hospital at home program is a very important tool that we use in complete care to help provide appropriate care for these patients when their care needs rise to the level of hospitalization requirements. And in a large part, patients in this program are refusing hospitalization. Their goals of care are to stay home and to get as much care as they can in that environment. So I think this case illustrates the flexibility that you need for inclusion-exclusion criteria, and of course the importance of patient care goals in making those decisions, as well as the fact that you can't just look at a patient chart and make a decision. You have to have the discussion with the provider in the emergency room or the provider in the hospital who's referring the patient to you. And then you can come to a much better understanding of what the patient needs are and whether or not they would be safe in the home environment. Next slide, please.
So I just want to talk about a case from our program. This is a very recent case of UTI urosepsis, actually. A 64-year-old man with a history of CAD, STEMI, sleep apnea, hypertension, hyperlipidemia, non-insulin dependent diabetes, came into the ED with urinary symptoms. He had dysuria, hematuria frequency. He had a little bit of a low-grade temperature. He was tachycardic. Other vital signs were okay, but then his white count came back, it was 21. His lactate was 3 and going up. And he had a CT abdomen pelvis in the ED that showed findings consistent with the UTI. He spent the overnight in the facility, got IV fluids, broad spectrum antibiotics, and the next morning was looking better. His lactate had normalized, his white count was coming down, his other vitals were stable. And so I think this case is a good example of a patient who we ended up taking to hospital at home, who on first review, when he presented to the ED, would have been inappropriate given the state of severe sepsis at that time. But after about 12 hours in the hospital, he got the fluids and the broad spectrum antibiotics, he was appropriate to take home, and he actually did very well. So I just think it's important to remember, don't write off patients after one review, especially with the flexibility of the fee-for-service waiver to being able to take patients from the floor. They don't have to perfectly meet criteria in the emergency room. So I would caution against eliminating patients outright. You can follow them through that initial period of stabilization and hopefully take them to hospital at home. We can go to the next slide. And so, I wanted to bring up COVID-19. It's still very much an issue and will be something that we'll be dealing with for this foreseeable future. I know some programs is a hard exclusion. Our program did start taking COVID patients, as I mentioned before. I just wanted to share a bit about our experience and how we had to adjust our criteria. So almost all of the COVID patients that we have taken come to us to our CHOP branch of our program, which is the completing hospitalization at home, where they're already on the floor. And they're usually coming to us when they need a few more days of labs and close monitoring, and they're typically still on some level of supplemental oxygen. Our max on our program is about 5 liters by nasal cannula. We don't have high flow. We found that most patients who were getting admitted with COVID would end up being candidates for treatments that we currently can't provide in the home, such as convalescent plasma infusions and remdesivir. That's why most of these patients are coming to us after those treatments to the completing hospital at home program. But we did have to think about additional criteria for these patients. Not only clinical in terms of what their respiratory status was and what their oxygen needs were, but also social. So if they lived with other people in the home and those people did not have COVID, could they safely isolate? If the patient required a lot of caregiving, who would that caregiver be, and do they understand the risks and did they agree to that? If it wasn't safe for them to go back home, if there were people with immunocompromise or at high risk in the home, was, you know, a hotel an option. This actually did work out for a couple of patients that we treated. And if the patient was reliant on a home aide, would the agency resume care? I think that was a big barrier for many patients, with agencies not sending the home aides back into the home for COVID positive patients. So that was another piece that we had to consider.
In New Mexico, we made the decision not to admit COVID-19 patients to hospital at home because of the risk of rapid deterioration. We rather had a monitoring program where patients were given pulse oximeters and thermometers, and then they could be followed with daily 1 or 2 phone calls per day to see if they were stable, getting better, or deteriorating. And then we could do a house call if needed to determine any further steps. Of course, that was initially. Now things have changed with remdesivir and antibody infusions that are available. In Albuquerque, we have outpatient infusion clinics for the antibody for patients who are considered high risk. So now we monitor patients, but if they're positive, we do refer them for early infusion, since most of our patients in our program are high risk by definition. For remdesivir, they still have to go through the emergency room, at least to start the infusions. Because they're so high risk, the outpatient infusion center requires that initial emergency room interaction. Next slide, please.
So this is our last content slide in which we just wanted to review some of the key takeaways and final tips. So again, your program selection criteria is ultimately going to be unique to your program, and it's going to fit the needs and capabilities of your program. I also just want to give another plug for creating screening tools, some that you'll use internally amongst your own HA staff, and then maybe a shorter, cleaner version that you can share with your partners so that you can standardize the referrals that you're getting. And remember to keep those tools updated as things change. I recommend storing them in a shared space that your team can access them, whether that's an internal website, some sort of wiki or app, you know, and keeping them updated at all times so everyone's referring to the same shared and updated criteria.
Another important thing is to be very flexible, avoid being rigid. Every case brings different points to the table, and there's nothing like a discussion with whoever's referring the patient to you to really get a feel for whether or not that patient would be appropriate for your program. So provider-to-provider communication, I think, is something that you should consider integrating as part of your decision-making process, along with flexibility. And as Pam said, you want to keep everyone informed on any changes to your program, to your admissions criteria, and that requires continuous outreach. In our experience, we would go out 2 or 3 times a year to sort of educate our potential referral sources on our program, what we were doing, how they could reach us, trying to streamline the process and make it very easily accessible. And then finally, I would like to point out, if you pay attention to the picture on this slide, that is a very important reason for hospital at home. It's a cat in this case, and many other cases it's the dogs. But those are often very important reasons why patients will refuse to be hospitalized. I think that's all we have. Did you have anything else to add, Pam?
No, that's it. Thank you.
Thank you so much.
Everyone, if you have any questions.
Thank you so much, Dr. Saenger, Dr. DePirro. That was a wonderful presentation. So we're going to now go to the question and answer section. There are a lot of questions. I am going to pick questions that are really directly related to the patient selection right now to start off with. If we have time for others, we might get to them. But I do want to say that we are going to take all these questions and work through them if we don't get to them live here for our Technical Assistance Center. Please go back to that website later to find some of your answers if they're not responded to today. I do also want to say we do have, I think, 3 examples of those detailed inclusion exclusion criteria from some sites on our technical assistance website. So if you're asking, you know, this presentation talked about how to create them, you can look at what some other programs have done in very detailed manner on our TA. So I'm going to now pick up some of the questions that were asked. So one of the questions dealt with how do you deal with behavioral health patients? And I know, Isa, you had mentioned a little bit about this. I don't know if you want to say any more regarding
All right, so like I said, that is really a situation where you have to consider it on a case-by-case basis. We've had situations where there was excellent family support, so we felt that it was safe, that we could provide the needed care and have a good outcome in the home. We've also had situations where the patient wanted to go home, but the family felt it was not safe and did not feel comfortable helping manage the patient due to psychiatric issues that were not well controlled at the time. So it really comes down to what kind of support you have in the home setting.
Yeah, I would say we rarely encounter that as an exclusion on our service. I think the rare instance that comes up is if we are evaluating a patient and the sign out or the notes indicate that the patient has been violent or aggressive towards ED or hospital staff, and that, you know, beyond their initial presentation, you know, when we're sending our staff into the home, they're often alone. And so that would be a big red flag for us. But in general, it's not, we don't often see it as an exclusion.
Pam, you had talked a little bit about, in the COVID part, about the aides and providing the direct care. How do you assess, like, how many hours of aid is needed to care for a patient where they might have some hours at baseline that they privately pay for? And how do you assess that?
Right. So there's always sort of what was the patient's baseline and what are they do? How are they doing now that they're acutely ill? And so Isa talked about this too, sort of having, we have sort of a short list of questions, whether the patient can do certain things on their own at home. If they're not ambulatory, they can't get to the bathroom, they can't handle toileting, they can't get themselves, like Isa said, a glass of water, they can't reach the phone or answer the door when someone comes. If they can't do some of those things, they really need to have 24-hour support at home. You know, with just the nature of hospital at home, you don't know what's going to happen in the middle of the night. If you need to send someone there to evaluate the patient, you know, there has to be someone who can get up and get to the door. We want to make sure that we're leaving our patients, you know, in a safe, supportive environment, and those are sort of the basics. You know, ambulating, toileting, feeding, access food and water, access to a phone, and answering the door.
And just to expand on that a little bit, you know, often these admissions are for elderly patients, and the main caregiver or the help person is going to be the elderly spouse. And it may not be ideal, but, you know, often the extended families can step in and help in those situations, so that hired caregivers are optional with the large families who are very willing to step in.
Yeah, that's a great point. Almost, I would say most of the time, it's family stepping in.
In both of your programs, who does this safety evaluation? Is it your providers who go into the emergency rooms, or how is that figured out?
I can go first. So for our program, we have a group of what we call recovery care coordinators, who are all of whom have a nursing background, and they are the ones who do the sort of extensive home safety and social screening. And that might be talking directly to the patient. If the patient, you know, is unable to provide all the answers, it might be calling the proxy or the spouse or another family member and getting that complete history. But it's done by that staff, those recovery care coordinators.
In our system, we usually start out with a provider-to-provider conversation, or at least talking to the discharge planners in the emergency room. So some of those first screenings about the critical mobility aspects are done at that level. And then usually the secondary part is the admitting provider will do, you know, the eyeball test basically, and determine, you know, if we need to consider alternative care.
One of the questions is that's listed here is, are you working with palliative care as well? Are you admitting patients who what might have gone to a palliative care unit in your hospitals?
So I'll address that first. So as I stated during the presentation, we now have a program called Complete Care, where it's elderly patients with multiple comorbidities. And most of these patients, we now carry about 700 patients in that program, are at least partially, if not totally, in a palliative care mode, which is why they are overall not going to the hospital no matter what, but will accept hospital at home if it becomes necessary. And we do have an extensive palliative care program here with Presbyterian. That's a consult service. So we follow the patients as their primary care providers in the home and do a lot of palliative care and can consult a palliative specialist as needed for further support. But a lot of those patients are our hospital at home patients now. Pam?
Yeah, I will say we do think about patient goals when patients are getting admitted to the emergency room. And, we'll take a patient who, clinically really, might require in-hospital care. But if their goals are, like I said, to maximize their time at home, that's not in hard exclusion. And we might, if there's a discussion about whether the patient would be open to hospice, if they really just want to stay at home, that, we have, and we do take those cases. I'll also mention that we have a separate program at Mount Sinai called Palliative Care at Home that sees sort of longer term follow-up for patients who require who have palliative needs.
Thank you. There's another question here about language differences. How do you deal with patients with different language as their primary language?
So in New York City, that comes up all the time. I would say, on a weekly basis, we're taking patients whose primary language is not English. And we rely really heavily on our, language line translators. And they do, everything from the screening, questionnaires, the, consenting, and then of course, all of the clinician care in the home will be dialing in those language line translators. It's the same if that patient were inside the hospital, it would basically be the same. So we do have that access and we use it all the time.
Likewise, in Albuquerque, we have access to our language line translators. We do not have, I'm sure, the variety of languages that you do in New York, but we do have a large portion of the population that's Spanish only. So actually, several of our providers are Spanish speakers. So we actually don't call the line as often as you might think.
Great. Another question here is, how do you get providers comfortable with sending patients home with your hospital at home program versus going upstairs, especially when you're starting off these programs?
I think I would say something that Isa emphasized, which was that provider to provider discussion. You got to pick up the phone. You got to pick up the phone and tell them what your program does, what you're capable of doing, talking through the particular patient and what their needs are. It's, like I said, it's a bit of a leap for a lot of clinicians to think about this care model. It's still very new in a lot of places in this country. So yeah, you've got to reach out and make your program's number, widely known and accessible, and encourage people to call with referrals, encourage people to call and talk through cases.
Yeah. And as I said during the presentation, the other thing we did was we actually would do little outreach meetings 2 or 3 times a year to partners that could be a good referral source. And inevitably you find that you end up getting several providers that really like to use you and will continue to call and develop a rapport. And there'll always be some providers that just do not think it's appropriate to send somebody from the emergency room home rather than up to the floor. But it's an ongoing process, communication and education.
And sharing successful cases. Yeah.
Mm-hmm.
Feedback. Mm-hmm.
I'm going to take one last question here, which is, do either of your programs give or titrate IV opioids?
No.
No, we do not. Yeah. We carry a first dose medication box. I can't imagine driving around if it became known that I carried opioids of any kind. No fun drugs in the box. That's the rules.
Great. We have many, many more questions here, and as I said in the beginning, we will get to those and answer them on our technical assistance website, and many of the answers are already there. So we wanted to thank our speakers again today. Can we go to the next slide? So again, our hospital at home website is listed here, and our TA website can be linked directly from the hospital at home users group, or you can go directly there through this link that's listed here. And so I wanted to say a thank you to our speakers today one more time. I also wanted to thank the John A. Hartford Foundation, which has helped us start the Hospital at Home Users Group and supports this webinar series, as well as the American Academy of Home Care Medicine and the American Hospital Association. Our next webinar is on Tuesday from 4 to 5 p.m. Tech Matters, Building a Strong Platform for Your Hospital at Home program. We also have launching next week the office hours, as I mentioned in the beginning, where you can just kind of drop in as long as you've registered to ask any questions you might have. And very important for us so that we can improve and learn from these webinars, there's going to be, when you leave this webinar, there's going to be a survey. We really would like you to fill that out. It's only 4 quick questions. And I think that's the end of our webinar, so thank you.